Hey, good evening, everyone. Thank you once again for joining us at the Fifth Avenue Synagogue Sunday night lecture and discussion series. Tonight, we once again have the privilege to hear from Dr. Larry Norton. Dr. Norton is a senior vice president at Memorial Sloan Kettering Cancer Center. We had the privilege to hear from him a number of times during the heart of the COVID-19 crisis and pandemic, and his presentations truly gave our community a measure of clarity and comfort, because early on, one of the greatest difficulties of the pandemic is that there was a lot of different explanations as to what is going on. It wasn't exactly clear what a person should do. And you coming on, spending time with our community, really provided our community with a level of comfort and clarity. And to have someone of your caliber answering our questions was a true blessing, and we want to thank you for that once again. Tonight, Dr. Norton's topic will be the world that COVID-19 made, 2019, 2022, and beyond. I would like to thank Honorary Fifth Avenue Synagogue President Ezra Merkin for arranging tonight's presentation. Ezra will be conducting an interview with the doctor, and Rachel Ackengold, Fifth Avenue Synagogue COO, will oversee the question and answer session upon the conclusion of the interview. And to formally introduce Dr. Norton, it's a great honor for me to call upon our dear friend Gail Propp. Gail is a member and a friend of the Fifth Avenue Synagogue community for many, many years. We have the joy of seeing her children and grandchildren at the synagogue on a regular basis. If I had to sum up Gail in one line, I would say is that she is constantly trying to do something for the community. And I've seen this firsthand. She must have arranged the COVID vaccine for hundreds, maybe, I don't know, 1,000. Who knows how many people she arranged the vaccine for during the crisis, staying up very, very late to try to make matches for people. She's always trying to organize, to fundraise and to assist organizations in fundraising. And she gets very excited when she scores a point to help a different organization. And I know from firsthand experience that she also loves studying Torah, and especially talented in giving beautiful divrei Torah. I've heard those as well. I want to thank you, Gail, for your friendship and everything you do for our community, and bless you only with good health to continue to uplift the Jewish world around you. And I call upon you to formally introduce this evening's program.
Thank you so much for your kind words. I would like to add my welcome to everyone. I am truly honored to have been asked to introduce tonight's program with Dr. Larry Norton. As you know, he will be interviewed by Ezra about our COVID world. Dr. Norton is world-renowned, and his bio is on the email we all received. However, I have a few words to add. I was diagnosed with breast cancer in 1992. My case was so unusual that mine was a topic of grand rounds at Mount Sinai. In order to find the best treatment option, I called the leading oncologists, both in the US and abroad. I gathered all the recommendations, and Dr. Bernadine Healy, who at the time was director of the National Institutes of Health, reviewed my file. Her response to me was, "Do what Larry Norton recommends." I had called Dr. Norton. I was an unknown person to him without connections. He reviewed my case, and I'll never forget, he called me back at 2:00 in the morning. I am grateful for this opportunity to publicly thank Dr. Norton for not only being the great doctor that he is, but for also selflessly and brilliantly training future generations of doctors. And now, Dr. Larry Norton and Ezra Merkin.
Thank you, Gail. Those are really difficult words to follow. I wanted to add my thanks to Larry, not only for taking exceptionally good care of my wife for decades, but also for letting himself be put upon by me, by others, almost always incredibly good-naturedly, very responsibly, always calls back 24 hours a day. We're going to start this evening with a few thoughts from Larry. He's got a presentation for us, and we'll all listen.
Well, obviously, Ezra, thank you for the introduction. Gail, that's very, very touching what you just said. And I'm sorry I woke you up at 2 o'clock in the morning. It was probably because I was going on an airplane at 7 o'clock in the morning, and I knew that I couldn't,
Absolutely.
and knew that I knew that if I didn't call you then, I wasn't going to be able to call you for a few days, So, but I'm glad everything worked out, and thank you very much for your kind thoughts. There's so much to talk about COVID that it's almost impossible to to cover even a tiny little piece of it. And I'm not going to cover the basics because I think at this point, we all know the basics, or they can come up in questioning later. But I'd like to cover some aspects of COVID that are not normally covered that I think are very important for us to know as we navigate our own health and the health of the nation and the world going off into the future. Let me show some slides. I have to go through screen sharing, and I have to do this, and I have to, hopefully it'll work. Yeah. Okie dokie. And now I have to get rid of my own image so I don't have to stare at myself. Good. So there's the old COVID virus, which we all know. The first point is that something that was actually coming up in discussion earlier that some of you might have heard before we began this is because we've been somewhat protected for the last few years by being careful of crowds, wearing masks, and where appropriate, and in some cases early on lockdown. We haven't built up a lot of herd immunity for common respiratory viruses. And this is especially in children, some of whom for most of their life have been actually in some form of isolation. As a consequence of which, we're seeing an explosion of respiratory viruses, not just COVID, throughout the United States, and it's really just beginning. These are the data as of November 19th, showing very high incidence of influenza-like activity, which includes influenza, respiratory syncytial virus, RSV, which is particularly dangerous for small children, and COVID as well, throughout the United States, and rapidly spreading. So this is something we really all have to be aware of, is the fact that there are still dangerous viruses out there that are not COVID. But COVID is still very much with us, and to illustrate that, this is the statistics as of this morning of the incidence in New York State. And you'll notice, if you could follow my beeper, that it's starting to rise, actually over the last 24 hours, 25%. And these are just reported cases, which is a gross underestimate of the number of cases. The vast majority of cases are not reported because either they're mild and people are staying home, or moderate and people are staying home, taking Paxlovid in some cases, and not reporting to health facilities, institutions about their care. So it's a really gross underestimate. A better measure of how serious the issue is hospitalization rates, and they're starting to rise also. You'll notice something interesting here is that we're kind of at the same level we were when we were all panicking back in March of 2020. And so we've gotten used to it. But the fact is that we're have the same kind of the incidence in the population that we actually saw when we were all starting to really panic. Now, of course, the death rate was much higher then because we didn't have as effective therapies, we didn't have prevention strategies, and because none of us were vaccinated. The real plus of the vaccination is to keep people out of the hospital. And nevertheless, we are seeing a rise in the hospitalizations from COVID in New York State occurring at the present time. So we still have a very real problem, and we have to be aware of that, and we have to act accordingly. And that's really one of the important points that I really think should be made in all of the discussion, which is that we're not behaving rationally. In fact, if you look at these are the colors about the percentages of Americans that have had a full series of vaccination, plus the most recent bivalent vaccine. And this bivalent vaccine was specially engineered to cover what has been the most predominant variant in the population. That's starting to change. We're getting a new variant coming in, but still that old variant is still out there. And you can see that even in the high penetrance states, we're talking about 25% of the people have had full coverage, including the bivalent vaccine. And that's not really rational behavior, considering how serious this disease is and considering that it still has a force of mortality, as well as making people very sick and keeping them out of work. And we don't know what the long-term effects can be of long COVID, and perhaps we'll talk about that later. So that's a great concern. Surveys have shown that throughout America, only about half people plan to get a bivalent vaccine, booster, and half the population says they would never get a bivalent vaccine booster for no good logical reason that we can come up with as physicians. And that is, of course, really of great public health concern for us. Best quote I've seen on this was from the dean at the Rutgers School of Public Health, Perry Halkitis. And you can read this for yourself. It's the management of all these pandemics have too heavily relied on biomedical understanding of the health rather than everything else, the social, structural, psychological, and behavioral factors. And in fact, medical professionals, as I put in bold, most well-intentioned, assume that prescribing, vaccinating, and giving directions is all their patients need. That's obviously not the case. The patients are human beings with complex lives, thoughts, and emotions. And you have to pay attention to their motivation, compassion, empathy, and reckoning of other situations. So this hits me every time, for the last year or so, I've had to, especially over the last half year, do professional travel like I didn't do before during the pandemic. So airports and train stations, people are not masking, even though they're very close together, and even though they're indoors. I've never abandoned my indoor mask. And I think most of my colleagues have not, except under very special circumstances. And of course, I'm fully vaccinated and boosted, which doesn't mean that I'm not going to get sick, but I've done everything I can to minimize those chances. And I think this is something we really have to wrestle with. There's certainly misinformation out there, but even among people that don't believe the misinformation, that still they're not doing everything possible to prevent these infections and other respiratory infections. And so I think this is one of the most interesting topics really related to COVID. It's not about the virus itself or our mitigation strategies, it's about human behavior. So what I'm going to cover right now is just a few things related to the impact on U.S. healthcare. One is about telemedicine, about what it means as we're getting older and the kind of care that we should get as we're getting older. About what is uncovered about healthcare inequities and what that means for us as a population, total population. Issues of drug supply, which you may not be aware of, but I think are important for us all to be aware of. Issues of public health preparedness and how important that is, and also practice patterns and how it's basically fundamentally changing American medicine in a way that actually could be productive, but it also could be very destructive. Now, telemedicine, as we all know, I don't have to belabor it, almost was non-existent prior to the pandemic. This is the current penetration of telemedicine. The Americas lead the way with about 40% of the telemedicine traffic being in the Americas, but also Europe is not far behind, and globally there's an increase in telemedicine, all over, much less in Asia. Interestingly enough, just beginning, and that's because in many parts of the world, and as Africa isn't even on this, access to the digital technology necessary for it doesn't exist, and that could be a worldwide problem. Telemedicine has been terrific. It enables quick office visits without people traveling, checking in, with the doctor. An enormous amount can be taken care of their history and even some aspects of physical examination. I'm not doing full physicals anymore by telemedicine, but I am doing aspects of telemedicine, and a lot of specialists are doing that at the present time. Most of it is clinical care, but there's also a lot of telemedicine in other aspects, making diagnosis, medical education, and in follow-up. And what I mean by follow-up is basically after receiving care to make sure the patients are complying with medicines, how they're doing, not having negative reactions, not having any complications of surgery, and so on. So it's become an extremely important part of what we're doing. Most of it's done by internists, although more and more is being done by people who are interested in preventative medicine, which is, I think, the biggest topic that is going to change healthcare, is preventing people from getting diseases. And you see a big chunk of this is psychiatry. The red pie piece there is my psychiatry friends are saying that it's actually more effective for them to actually see many of their patients by telemedicine than it is in person. The patient's more relaxed. They see their home environment, and that I think is going to be a growing portion of what psychiatrists are going to be doing, is doing it by telemedicine. Also, access when people are in trouble, they'll be able to reach a health professional very, very quickly. The downside of all of this is that it's largely in people of high income. People of low income is 0.3%. And it's and this is a problem because access to technology is going to be absolutely essential, and familiarity with technology if telemedicine is going to have the impact on healthcare that we think that it really should. Another topic that I think is relevant is how we're going to change how we take care of people as they get older. These are the deaths over a period of time in nursing homes from COVID-19, and you can see that even up to the present time, it is still these are weekly numbers. These are I believe weekly or monthly numbers. I can't see the bottom of my screen, but you can see that it's still considerable. And putting people who are most vulnerable in a setting where they're very close together is a guaranteed way that you're going to spread infectious diseases. Now, you'd imagine that there'd be a rationality about all of this with the health workers in those areas being fully vaccinated and being very careful. But it's not true, except for Puerto Rico, which has had the highest penetrance of vaccination among people who are working in nursing homes. Everybody else is under 50%. If you want to see where New York is, it's about 25%. And this is fully vaccinated, including the most recent booster. So that if the people working there are not protected, half the people with COVID are asymptomatic. And so feeling healthy doesn't mean that you're not carrying the virus. And if you're carrying it into a vulnerable population, I have visited nursing homes and I've seen that mask wearing is a very iffy thing, as well. And especially very old people who are frail really don't like wearing masks. They don't communicate well. They don't hear well. They need to lip read a little bit to communicate. And so I think this is a big problem. Where it's going is a tremendous movement toward keeping people at home and taking care of home with home services of various sorts, including medical care, including home visits. And a lot of those home visits not being done by physicians, but really by what we call physician extenders, nurse practitioners in particular, and physician's assistants. And we're seeing a big movement away from nursing homes and even assisted care facilities into keeping people at home with additional services. That's one of the growing areas in contemporary medicine in the United States. And I think we're going to still see that. We're going to continue to see that happening. Another thing that COVID has uncovered, we've always known about discrepancies in healthcare and uneven penetration, but the COVID epidemic in the United States has really just shown this, very clearly in a glowing spotlight. If you look at death rates of people who are Native Americans or Alaskan natives, it is over twice what it is of people who are white, non-Hispanic. Blacks, African Americans, non-Hispanic, again, almost twice. Hispanic and Latino persons, almost twice. The Asian population is doing relatively well, and I think that it's a topic for sociological study why that is the case. Higher amount of vaccines and in general greater caution, greater care. It is common when I walk down the streets of New York to see that the people who are wearing masks are Asian, and I think that this is something that is really a lesson for all of us. But some of this is just penetration of care, inadequate testing, inadequate care, a lack of access to facilities, lack of access to hospitalization. And the differences, the discrepancies in healthcare in the United States are really glaringly obvious here. And this is something that we're spending a lot of time and a lot of attention to trying to correct. Another topic that hasn't received a whole lot of attention is drug supply. Supply is complicated. You have to get the raw materials. You have to be able to manufacture the drugs. You have to get them to a wholesaler. Often it has to be repackaged between the time that it's manufactured and it goes to the wholesaler. And then there are secondary wholesalers who deliver it to pharmacies and hospitals and eventually get to patients. This is a very complicated supply chain. Just focusing on this part of it, most of the supplies that have to be used to make drugs in the United States are not in the United States. They have to come from overseas. And it's still at the present time, most of the manufacturing is not in the United States because frankly, it's been less expensive to do the manufacturing in other parts of the world, particularly China. And then it has to be transported into both those places before it could actually reach the next steps, which is distribution and eventually delivery. This puts us at great risk, and not just for COVID medicines, which is a minor part of it, great risk for all medicines in case other things happen that will disrupt the international supply chain for getting, even if we can upgrade manufacturing. So Pfizer's making all of its vaccine right now in the United States. But even then, where do the raw materials come from? And so being global is a wonderful thing, I think. On the other hand, it makes all of us very vulnerable when the supply chain breaks down, as it has. because of illness, because of lockdowns, because of transportation issues. And I think this could be an enormous threat to all of us for all drug supplies moving off into the future. And we haven't solved this problem yet, and a lot of people are thinking about how we can. In terms of public health, it is also spotty throughout the United States. And even in the places that are really relatively well served, such as New York State, it is still grossly inadequate compared to the needs. But in many parts of the country, it is even worse in terms of the penetration. For Texas, which is a huge amount of the percentage of landmass of the United States. And for infectious diseases, this is a critically important topic because somebody who gets COVID here or gets on an airplane and comes here is going to be a source of infection. People travel all over the place. The health of any one individual anywhere is the health of everybody when you're talking about infectious diseases. And it's not just infectious diseases, by the way. The person who's driving toward you in that car, you've got to depend upon their eyesight, you've got to depend on their reflexes, you've got to depend on their skills with driving the car. All of that depends upon their health. And if their health is not good because they can't afford good health care, that puts your life in jeopardy because of an auto accident. So that the health of the entire public is critically important for the health of everybody within the public. And that's an important lesson that we've learned, and it's crystal clear when we're talking about an epidemic, when we're talking about an infectious process. And which gets us to, I think, one of the most important topics that we have to know about is that we are nowhere near ready to deal with the next epidemic. This is not the last one that we're going to see. This is just a list of the kinds of epidemics that are really, everybody's expecting that any of this could happen. Anthrax, avian flu, the coronavirus is not even at the top of the list. Hantavirus, which is in the United States, which is in the deserts of the Southwest and is a very, very, very lethal disease. Legionnaires is still among us. The respiratory virus associated with the Middle East is just another virus very similar to the coronavirus. Influenza, even our best vaccines are only about 50% effective. People think that when they get a flu vaccine, they're home free, but they're not. They'll get a milder case of the flu if they get the flu, but it's not protecting them. And of course, the big dangers that we're really afraid of are what are called viral hemorrhagic fevers, of which you've all heard of Ebola, which has upwards of a 90% mortality. We actually lucked out with COVID-19 that has such a low mortality in the single digits, even in the unvaccinated population when it first hit us in the United States. If it had a mortality of 10% or 20%, or imagine even 90%, you could imagine what kind of impact that would have had. Now, what do you do about these things? Well, we know how to deal with it. We have to be able to identify it and test for it. If somebody has it, you got to be able to do contact tracing. You have to be able to discover drugs like the viruses, like the vaccines that we've made in record time, in historical record time, but also drugs that may be able to mitigate the dangerous effects of the virus, like Paxlovid and like the monoclonal antibodies. It was extraordinary, and I think it was a great victory for the American pharmaceutical industry, which is under a lot of pressure now because of drug pricing. Clearly, the respectability of the drug industry went way up because of the rapid way that it developed the vaccines and basically saved us all throughout the world. You've got to be able to distribute to everybody the various drugs, the vaccines and the various kinds of drugs, and therefore the issue of healthcare disparities becomes an extremely important topic. Educate the public, and educating them is not enough. And I'd like to hear some of your comments about how we make people behave and do the things that we know and everybody knows they should be doing, like being careful about not being exposed to the virus and getting vaccinated when the vaccines are available. Educating them is not enough. There's also got to be ways of motivating people to do things that are in their self-interest as well as the self-interest of the whole population. And you need people to do all of this. Now, it's not just MDs and RNs and we call APPs, that's nurse practitioners and physicians assistants. All right. This is a huge problem at the present time because we are actually seeing a shrinkage of the ability of personnel to do this, and especially the people who can actually dedicate themselves to these tasks if there is another healthcare emergency or disaster ahead of us. There's been discussion about actually forming a medical national guard where volunteers in these areas, as well as retired physicians and maybe even advanced medical students, can be mobilized at a very quick pace to be able to do these jobs when absolutely necessary, should this happen. And there's been a lot of discussion about this as well. But having the adequate personnel is very important. And that gets us really into our last topic, which is the impact of COVID on medical care in general and on medical personnel. We'll just use mammographic screening as an example because I'm most used to it. When things we had a fair stability in mammographic screening. Remember here, it's only about 50 to 55% or 60% at the max of the women who should be getting an annual mammogram were getting it when things were good. When the pandemic hit, when I first spoke to you about the pandemic, before we actually had vaccines, it was a dramatic drop, almost to zero in cancer screenings. These are the diagnostics. Somebody who had a lump will get a mammogram, but even the people with a lump, there was a considerable drop in the screenings. And this was really a healthcare disaster. Slowly with the vaccinations, it rose, but it's still down 15, 20% compared to where it was pre-pandemic. Cancer is not stopping. People are still getting breast lumps. People are still getting breast cancer. We're just not finding them when they're small. And this could be an enormous impact on the health of the population. But something that is not commonly appreciated, it also has an enormous impact on the structure of the economy of American healthcare, which is a fee-for-service system in general. So if you look at, and this is something that we can measure in Medicare physician spending, where it was stable before the pandemic hit, March of 2020, and then went way down because people weren't even coming in for things like chest pain, and people were dying of heart attacks. People weren't coming in for bleeding and had very serious bleeding, even fatal bleeding episodes. They were afraid of getting COVID in that situation. But also you can actually measure that by the decrease in spending. And then it came up, and now it's sort of stable at about 10% less than it was before. Now, people say, okay, great, that's wonderful. People are using doctors less, and actually it's true. This is from the American Medical Association, and this was from the summer of 2020. In this regard, there was a huge drop in the physicians' practices revenue. Why that has an impact, it's obviously come up since then, is because if you look at the percentage of hospitals reporting staffing shortages, and also the inpatient beds by COVID, you can see they match very, very closely. Is that the as COVID is increasing, the staffing shortages increase. Even now, as the number of beds is going down, we still have about 10% of hospitals showing critical staffing shortages. Why? Because people can't be paid enough to work in hospitals now. They're getting better paying jobs in other parts of the sector. We call it the mass resignation. And also with decreased income, there's less money to be able to pay people and be able to raise salaries. So the staffing shortages are partially caused by hiring practices, which occur because of this. And so people are still getting sicker. We're not seeing them, and we have fewer people to be able to take care of them. So these are the points I want to make, just in brief summary of some of the points that I want to sort of address in this, and we could cover dozens of others. The pandemic is not over, and we still have an epidemic of flu and other respiratory viruses. It's going to have a lasting impact on healthcare in many ways. There's more telemedicine, but it's unevenly applied. Another issue is the fact is that I have patients who've seen me from California, and when they go back to California, I can't do telemedicine with them because it's not allowed in California. I can speak to them informally, but it's not a really good medical consultation, so we don't have national licensure, and so it's a great tool, but it's unevenly applied, and we see that healthcare disparities is here as well. We're seeing a big shift toward more care at home. Just imagine all of us testing ourselves for COVID at home with home care kits. I mean, that's an unimaginable thing a few years ago, pre-pandemic, that you would actually be doing that and actually calling a phone number and getting Paxlovid and treating yourself. And this is going to happen, especially with the older population, as there's more utilization in nursing homes and in assisted living facilities, because they're turning out to be dangerous places. We've mentioned the healthcare inequities already and disparities, and I think this is a critically important topic, because the health of any one of us is the health of all of us. We have to address drug supply issues, or we're going to have significant shortages of common drugs moving forward, especially if there's other disruptions in world relationships, such as wars, for example. We need to grossly upscale preparedness and get ready for other epidemics that will occur, and also get people to do the things that we already know that can reduce their risks, which they're not currently doing. We have to increase preventative measures and screenings, which have gone down. We're kind of panicking in the breast cancer area because we know that there are breast cancers out there that we're not diagnosing when they're small, and it's going to be hard to take care of them, and it's going to be associated with increased death rate. And that applies to colon cancer and many of the other things that we have to deal with. And I think we're going to need to re-examine the fee-for-service model of healthcare. The other way is capitation, where facilities are paid to take care of a certain population, whether they're sick or they're healthy, and we're not going to have fluctuations in healthcare economics. And the fee-for-service model is going to have to be re-examined as we move forward, because many physicians have gone out of business. They can't practice, and obviously there's physician burnout in this situation as well. They're not going to be there for us when we need them, and this could be a very serious thing we're going to have to deal with. Thank you all very much for listening, and I'm going to stop screen sharing and have further conversation with Ezra and with the rest of you.
Thank you, Larry. Very, very much appreciated. As always, as thorough a presentation as one could possibly hope for. I'd like to pick it up with the quote that you started from with Dr. Halkitis at the School of Public Health in Rutgers, and wonder if you were to play for a moment a role that you sometimes like to play, which is sort of the czar of the universe and czar of allocation of resources. If you look at the amount of money that's spent on medicine, and to bring it home, look at the amount of money that's spent, for example, in trying to develop and really make effective, say, one drug in oncology or any other specialty that you pick, compared to the amount of money that's spent on public health. Broadly speaking, we know how to do public health. There are lots of sub-issues that need a lot of work and attention, but public health as an area is monetarily starved. It's very hard to raise money for public health. COVID is, as you always have emphasized, as much a public health issue as it is a medical issue, particularly once we made those incredible strides in trying to figure out how to cure COVID. A lot of the rest of it was public health issues. Your map is particularly alarming because if you adjust it for population centers rather than for land masses, so for example, New York is colored actually fairly favorably, but if you look at Texas and Florida, they're the worst possible color, the worst possible shade. And so I guess my question is, the bang for the buck in public health is so big, so measurable, and so in hand that I sort of wonder, is there something that could be done on a national basis and then obviously on a state and local basis that can just be so much more effective dollar-wise than some of the monies we spent on medicine?
Well, the whole issue of medicine pricing is a big issue and a complicated issue. And I think we can't really touch it now because it was just gobbled up every second that we have, and 4 or 5 hours more than that.
Sure.
But the fact is that an enormous amount is paid for. There's an enormous expenditure actually to develop the drugs, all right, and there's no question about it. But Americans spend a whole lot of money on a lot of other things as well, all right, that are by choice, sports. I mean, for an example, and
consumption generally is
right. Consumption is high in many of the areas rather than, and so if there was a czar of the world, I'm not pretending that I even have any aspirations there. Sorry, Ezra, despite your comment, is that I think that there's an enormous amount of reallocation that would be necessary, to that would be productive, in terms of accomplishing universal health and universal happiness, I think, as well in that particular regard. But the big difference is obviously, there's a profit motive in drug development. There's no profit motive really in public health. It's got to come from the public sector, not from the private sector. All right.
Yeah,
That's the issue that we really have to wrestle with. We kind of know what to do, sort of, and I want to go back to that in a second. We know what to do, but to get it done right, it's going to take like a national will. When there is no specific, there's a health motive, but not necessarily a profit motive for doing so. It's like that's one of the things that we're going to have to wrestle with. But I think that as an important a topic is, as that is, which is a very important topic, is throwing more money at it, would that solve the problem? I think it wouldn't. Although clearly there's other things we can do, to have the personnel for contact tracing, or to have people ready. I think having a national mobilized or national guard kind of force ready to move on this particular guard as well is actually extremely good idea. But even though now we know, all right, what to do, people should be vaccinated and should get the bivalent booster. All right, okay. Only in the good places like New York State are 25% of people fully compliant. All right, only in the good places. Everybody knows it's a respiratory virus. You get it from the breath of other people. All right, and everybody knows that they don't have to be sick, that they can be giving to you and they're perfectly healthy and asymptomatic carriers. And yet, we see people in crowded indoor situations unmasked every place. And wearing a mask is just not that uncomfortable, frankly. It's just another item of clothing. I gave a talk up in Boston recently and at MIT, and it was an international session, and the people that were coming over from Asia were just sort of shocked that people weren't wearing masks. I was wearing a mask in the room. There were two other people wearing masks, and I happened to know they had health reasons why they had to wear a mask, and everybody else was really unmasked. One young scientist had come from South Korea, and he said that this would never occur there. Everybody would be masked in an indoor setting like that all day. And so, even though we know what to do, and we can manufacture the masks, and even if we distribute them, people are not wearing them. So I think a bigger issue. I think as big an issue for us in terms of public health is how to get people to behave rationally for their health and for the health of the people they care about.
Right. So I'm pretty sure I'm right in assuming that the talk you gave in Boston was to a highly educated audience, highly educated scientifically and medically, extremely sophisticated people. And when I was talking about funding, I meant as much government funding as anything else. I don't think public health is something that ends up getting done commercially, for a living, for a profit. And again, making you czar, at least for the medical universe for a moment, are there things that you would think of? Is there low-hanging fruit that we can identify and pursue in advance of your list of horrors of the next dozen catastrophes, or is it just not that simple?
It would be simple if humans would behave rationally. We know what to do. I mean, basically, and to the very best that we can. We know what to do in all those areas. And then my next to last slide, was a list of some of the things that
there was some prescriptions, right.
And there are things that really sort of need attention. We need to do. Getting it done is the challenge, and it's human behavior that I think is the fundamental challenge before us. Not the intellectual, aspects of it. We could, and I'm not going to reiterate those things. It's on that slide, and people can see it if they see the talk again. But and those are just a few of the things that can be done. It can be done. Some of it can be done locally. Some of it takes a national will, because again, too, is that anybody can get an airplane and travel anywhere, and so just having New York City or New York State safe is not going to protect us very much at all, especially a place like New York, where people are coming from all over all the time here and sort of mixing. So it's how to modify human behavior so that they behave in a rational fashion. I think is the biggest challenge before us. And frankly, I mean, just I'm in a synagogue right now. Frankly, I think there are real lessons to be learned from our religious traditions. In terms of how to get people to behave in a rational fashion. All right. Pretty much everybody on this in the session knows more about that topic than I do per se, but it's been very, very meaningful. I may be circumcised for certain reasons, but it also dramatically decreases my chance of spreading viruses that can cause cancer, both in my partner and in myself. I may be eating kosher, which I do for certain reasons, but also by doing so, I've significantly decreased my chance of catching certain diseases which occur with certain foods. Trichinosis, obviously, but also seafood, can carry some very serious diseases, as as we know. And when you see food recalls, you very rarely see food recalls of foods that are kosher. So I think that to give you some example of public health things that are really part of our tradition in Judaism, and many other social behaviors, obviously, in terms of relationships between us as humans, and as well, which I think are critically important. So I really think that the world has a lot to learn from those things as well, in terms of how to actually get people to behave in a fashion that's good for themselves as well as good for everybody else.
Yeah, look, in that wonderful talk you gave us on Maimonides as a physician, there were strong elements of public health in that presentation.
Yeah, right.
Very much so.
Right.
Thinking a little bit about COVID and medicine, curious to hear to learn what you have to say on almost the sociology of medicine. To what extent has COVID changed the simple taking care of patients outside of COVID as well? To what extent has it affected the delivery of medicine, for example, Memorial, either both on a patient doctor one-on-one relationship and in terms of the hospital as a whole? How does the hospital begin to think about changes that have been brought about in its area, which one would not think of as the first frontier of COVID, that come out of COVID and are here to stay, are not going to disappear if we could be rid of COVID on the wave of a hand tomorrow?
Or just a few pre-comments. Unless better vaccines are developed and unless people take them, we're never going to be out of COVID. This is COVID-19. There will be, there's all the chance of COVID 2023, COVID 2024. We will have other kinds of diseases that we're going to have to take care of moving forward. So the changes really have to be, we have to consider them permanent. Now, I do think better vaccines are coming. That's a separate talk. There are vaccines being developed to give what's called mucosal immunity, where you give the vaccine into the nose and you get actually resistance in the nose, so the virus never attaches. And then that will actually stop those asymptomatic carrier problems. But then, of course, you're going to have people do it, and you have to have people use it, and then that's the same issue that we were talking about before. In throughout medicine, we've made certain changes that I think are going to be that are going to be permanent. First of all, we're much better at scheduling now, so that our waiting rooms are pretty much empty. They're not totally empty, but they have they have 10% of the people they would for in them, because we used to have people come and wait, and now people come at a certain time, they're seen much more efficiently, and we've gotten much more efficient, especially with things like radiology, for example, radiation therapy, chemotherapy administration when it's scheduled for non-doctor visits. And even with doctor visits, we've gotten much more efficient. Part of that is because we have much more reliance on our nurse practitioners at Memorial to do a lot of the things that the doctors were doing before, and they could do that very efficiently and prepare the way. Similarly, with telemedicine, it's not uncommon for me to do a telemedicine contact with my patient a week before I see them, so that I cover everything we have to do about the talking part of their care. So when they come in, I just have to examine them and maybe do an X-ray, and then they can leave very, very efficiently and not spend a lot of time there talking, because I could talk just as efficiently this way to my patients, or better, more easily to my patients this way than I can by having them come in. So actually, the scheduling has gotten much more efficient, and that's been a big plus. On the downside is we have a personnel problem, a very serious personnel problem. Hiring the right people, hiring them at salaries that they will come to us for, that we can afford, is a very big issue. We know there are diseases out there that are not being treated at the present time. Suddenly COVID didn't all of a sudden cure all those other diseases that we're not seeing in the same numbers that we saw before. So they're really out there, and then we could have a tsunami of these diseases coming forward, and that could change things in a negative direction as well. I think healthcare economics really has to change. To adjust to these things. I mentioned a few of the things before. You and I just were talking briefly about drug pricing. I think that's going to have to change as well. So it's a fundamental change. It's a fundamental change, in medicine moving forward. But it's also accelerated something else that we haven't spoken about, which may be a topic that we can talk about really at a later date, which is part of the reason why people aren't doing the things that they should be doing is because they don't believe authority figures. And they can't identify the difference between somebody who really knows what they're talking about and somebody who just has access to the internet. They say in the internet, all opinions are created equal. And so it's also called the death of expertise. And so I'm seeing an increasing proportion of the patients that we see who will come to us with preconceived notions because of what they read on the internet the day before. and disagree with our opinions because they say, well, I read an authority last night on the internet who disagrees with you, Dr. Norton, and so I'm going to follow that point of view, and not having any idea of whether that person knows what they're talking about or not, because it's very easy to look like you're authoritative, on a web page. And so I think the lack of ability to identify who to have confidence in among the general population, all right, and then the lack of willingness to follow the recommendations of those individuals, I think is fundamentally going to change American health and American healthcare. It's almost a perfect storm because it followed a sociological phenomenon, which is called patient empowerment. Is, my job as a physician used to be, and I still try to do it, is to give the very best advice I can, and not to do what is currently the accepted thing, which is these are your options, A, B, C, and D, okay, and you decide. Okay, and I'll treat you anyway, A, B, or C, or D, because you're in charge of your healthcare, and now I'm empowering you to make that decision. Okay, and as illogical and as irrational as it is, that's a very important part of modern healthcare, which is patient empowerment. And you decide really what's best for you. Is there some coercion on my part to make sure that I steer people into what I think is going to be the best thing for them? Absolutely. I think that's really my job. The other thing that I do, which is not commonly done in medicine, is that if I think a plan of action is really not in the patient's best interest, I will do what I can to find them a doctor who is willing to treat them with that and not do it myself. Right? But, because of my seniority in the field, I have a privilege that I can actually do that. All right. And I actually, for the most part, it's hard for physicians to turn down patients because it's not only turning down a patient per se, but it's also turning down a referral pattern necessarily if you get the reputation. Larry, I send a patient to you and you're not taking care of them. That's not good. So I think we're seeing major sociological changes, some for the better and really some for the worse, and those are things we're going to have to pay attention to. We're going to have to think about. I give a lecture sometime, and I've given a lecture in the past on how to be a successful patient, and it covers some of these points. And it's been translated into about 12 different languages, by the way, on the internet, if you want to look, and it's been modified, by the way. They still use my name associated with the speech, but it's been modified, to be culturally appropriate for that period of time. But how to actually navigate the healthcare system, especially now as it's changed because of COVID, is I think that's something people ought to be aware of.
Interesting. Larry, two fast questions that not quite the same. One is, to what extent can we derive some comfort from the absolutely wondrous scientific miracle that accompanied the diagnosis and cure of COVID? And to what extent are the principles of science that underlie the vaccines and the boosters applicable to the list of disasters that you put up on the screen earlier in the hour?
Well, I think mRNA vaccines are really a very significant advance, and right now the companies are trying to, in full disclosure, I'm very friendly with some of the people that are involved with Moderna in particular, as well as Pfizer, in this regard, particularly Moderna. That the mRNA vaccines are really terrific, and people are trying to develop cancer-specific mRNA vaccines now. And we have targets now for the first time ever in history that potentially vaccines could be useful for that particular purpose. The bigger issue is not the science. The bigger issue is the medicine. Is the business. All right. Moderna was very much on the rocks and almost not going to survive as a company until COVID came along, because they had a technology and didn't have a use for it yet. They didn't have a product. All right. And it was just basically not only the courage of the people working in the company, but the courage of investors that kept it afloat, so it was ready for it when the world needed it. And it's really quite a fascinating story from a business point of view. And so I think that we need other innovative ways of thinking about the funding of biomedicine, so that we are ready to move quickly in exciting areas when those exciting areas become apparent, but also keeping some very good ideas on slow burn, so that when their utility becomes apparent, that they'd be able to quickly be upregulated and there's increase in activity moving forward. And it's very much like the question that started the discussion about public health versus development of medicinals. Yeah, public health critically important. And is there a balance between that and the development of medicinals? No, totally out of whack. Similarly, I think that there is that we're not paying enough attention to having the national resource to be able to move quickly, especially in the area of infectious diseases when we need it. You need to do that. And I think that's going to have to fall into the area of government, frankly, because I think that, that's not, but I do think that there are other potential source of funding for that. People who are interested in, fixed income returns, and you certainly know, reams about finance better than I do in this regard, retirement funds and other things where there's the significant money that would accept small rates of return to be involved in this area. And somebody who has written extensively about this is an economist named Andrew Lo, L-O. And if people wanted to Google some of the things he's written about it, I think he said a lot of very wise things.
Last question, Larry. You're talking to an audience of parents and grandparents, some of whom perceive their children and grandchildren simply to be sicker this fall and winter than was the case a year ago, and wonder what there is to be done about that, both on a preventive basis and a cure basis. And on the other end of the population spectrum, in taking care of rather older people who, for example, really do fight masks and other. This is a very micro rather than a very abstract question. Are there things this audience should be attuned to?
Yeah, no, I think, the vaccination, very important. The vaccines are slightly different in the age they can receive it. Children should be vaccinated. Children should be boosted. I think children should wear masks much more than they do. All right. Frankly, in terms of spread of disease. So, my granddaughter, danced recently in a little dance recital, and some of the kids were wearing masks and some weren't, and I think some of the parents, we're careful about that. The problem is that we haven't had that herd immunity, as I said before, is that people have been real isolated, so that a lot of these kids have not been exposed to the virus, or enough of them have not been exposed to the virus that it's easy to pass it from kid to kid, because they don't pass it to the intermediary of a kid who's got antibodies and who has has resistance. So we are seeing an explosion. The pediatric hospitals are really, having a severe problem in terms of taking care of the kids who are really getting sick, particularly with respiratory syncytial virus, but there are others out there that are actually causing the problem. So I just think that the public health maneuver of trying to keep your kids as much as possible away from other kids and wearing masks more. I'm a mask fan. There's no question about it. I really think that masks are just the simplest thing that we can do. And N95s, not cloth masks, which have very little protection associated with them. The medical grade masks are better. The N95s really convey the best level of protection. It's not 100%, it's 95%, but it's 95% is still a pretty good number. And so I think that people should be wearing masks much more than they are. I wear, not all theaters are mandating masks. And by the way, it doesn't have to be mandated. I don't know any law that says you have to wear pants, but most people do.
Oh, yes, yeah.
And it's, I think rational behavior, there probably are laws that say that you can't go nude, but so maybe it's a bad example. But the thing is that people do a lot of things because they want to do them, rather than being forced to do them. And I think people should want not only to be healthy, but I think people should want other people to be healthy. And so I think that's one of the simplest things that all of us can do under those circumstances. Restaurants, we're not. You're not able to eat through a mask so easily, although I do a very good job on airplanes, I must tell you, and on trains, of eating with a mask on by taking it off, eating and putting it back. But I think that obviously that's hard to do in a restaurant or whatever too. But you could wear a mask when you go to your table. You could take your mask off when you're eating. You could put the mask on when you leave your table. All right. That most of the contagion happens when you're passing other people as you're going through. You're actually close to very few people when you're actually at one table. So you're limiting your chances of getting contact. So just rational human behavior is the thing that people should do for the time being.
We have about 5 minutes or so left. I'm just wondering, Rachel, are there any questions that you've seen that you'd like to put to the good doctor?
Yes, thank you so much, Dr. Norton. It's always a privilege to have you here. And I'm also in the group that feels some personal gratitude to you, as you were the doctor for my mother-in-law for many years. But very grateful as well for the wonderful presentation tonight. And there are several questions that have been submitted. And maybe I'll start off by asking if you could address the extent to which the debate around COVID has permanently weakened the public health infrastructure. There was so much pushback on COVID, whether whether it was masks or quarantines. The question, I guess, really is, will local public health departments have the capacity to issue mandates in the future? And in the same vein, we had a question from the audience as to what we can do to lessen political influence on the CDC and other government agencies that have influence on healthcare.
Honestly, always the hard questions come at the very end, Rachel. I don't think that COVID caused the distrust in public health authorities. I think it was always there, it just uncovered it. But I think that, obviously some of our leaders could have behaved better in that regard by being more supportive. And I'm talking about leaders, not just political leaders, but other leaders in that regard. And so I think it's really going to be a matter of leadership moving forward. In terms of instilling the confidence and again, it's that issue that I was talking about before, which is the death of expertise, people not knowing who to trust and not trusting people who they really should trust because they can't identify who to trust in that regard. If I had to put my finger on, and I'm not even going to get into the political issues there too in terms of those things, because those things are just very complicated and it really requires extensive, calm discussion, and probably a panel, people with different points of view in this particular regard. But if I had to put my finger on the Zen essence of the problem, as I see it, just as I see it personally, all right, it's lack of scientific education. I think for the most part, we have an enormous amount of ignorance in the American public in the scientific method, what science really does. Science is not a belief system. Science is based on evidence. Science is based on experimentation. People don't know how to evaluate evidence when it's presented before them because they haven't been educated in how to evaluate evidence. Simple statistical things such as, p-values, for example, and medians. When I give public talks, they have no idea what I'm talking about, and probably most of you don't know what a p-value is, but it's a very important thing to know. A difference between a mean and a median. And I think that the fact of the matter is that if people are not educated in the basics, not in terms of sophisticated areas of science, is the chemical structure of nucleic acids. That's not what I'm talking about. I'm talking about how to actually evaluate evidence, how to look at data, and how to evaluate whether the information you're receiving is valid information by actually looking at it. I have this issue as a physician all the time where I say such and such would be the way you should advise, and then people say, well, somebody told me that wheatgrass is just as good, and they're an expert too, right? All right, you're an expert and you're telling me that I should take tamoxifen, and they're an expert and they're telling me I should take wheatgrass. Why should I believe you and not believe them? And my credentials don't mean anything to them, or my experiences don't mean anything to them, because basically all opinions are created equal. So I think that we have and there's nothing that I've ever said in public or in private, to my knowledge, that I can't back up with evidence. When I'm talking about science and medicine, is that it's all evidence based, and much of the evidence is published. It's gone through something called peer review. It's published in journals that have gone through the peer review process. A lot of people don't understand the difference between a brochure and a peer reviewed journal. So I think it's basically we failed America with poor science education. And I think with more of an emphasis on meaningless scientific facts that kids learn and then forget, what's the valence of copper, which you learn for a test and then you immediately forget it, and not what are scientific methods, how can you evaluate evidence, what are statistical techniques, and how when you read something you can tell whether it's something you should rely upon as true knowledge, or say that it is not really valid. So I had to put my finger on the Zen essence of the problem. That's it, poor science education.
So, the anti-vaccine movement and the anti-vaxxers became so noisy during the COVID pandemic. Do you see vaccine resistance continuing to spread, say with measles, for example, and the recent, episodes of measles that they've been seeing in New York and elsewhere?
Well, it very well might, but if anybody would look at the evidence and look at the incidence of fatal COVID in vaccine populations versus fatal COVID in non-vaccine populations, the evidence is so clear and so overwhelming, all right? It's not a matter of opinion. It's not a matter of belief. It is a matter of evaluating the evidence, I happen to believe in God, okay, but I don't believe in science, okay? The science is not a belief system.
Mhm.
Science is about weighing the evidence, okay? And the evidence can change and opinions can change, right, when the evidence changes. In that regard. I mean, I remember all the controversy with masks because initially it was thought that masks weren't helpful, okay, because most of the COVID was being spread by contact, okay. As the evidence, and so the experts were saying we don't have to wear masks because the evidence at that moment, very early on in the pandemic, is that it wasn't useful. As the evidence became clear, is that it was a respiratory virus, and then that contact with surfaces wasn't the major way it was transmitted. The recommendations changed based on evidence. Okay, and there's still people saying that the scientists don't know what they're talking about because they said no masks, and then they said masks. They don't know what they're talking about. The evidence changed, and so the opinion changed. And that's something that anybody who knows about the generation of scientific evidence and scientific information would would understand. And so people don't understand that because they don't understand the basis. Yes, I think that there's a big issue with people who are afraid of vaccines. And frankly, these mRNA vaccines are the safest medicines we've ever developed. And the evidence supports that. It's not a matter of opinion. It's the evidence supports that, okay? And that is what people have to be able to look at and be able to make their own rational opinions. I don't want anybody to just do something just because Larry Norton says so. I want them to do it because Larry Norton can show you the evidence that that thing is good for you, and you can accept that evidence because you can rationally weigh that information and make a good decision for yourself.
Thank you. We've had a few questions that are practical questions about living in a COVID world, and I was wondering if I could pose a couple of these to you. One is, how do you think about the risk of indoor dining, weddings, and the like? Are there statistical levels of illness or hospitalization at which you feel the risk is tolerable?
Right. Well, I'm gonna have to. Unfortunately, I have to leave very soon because I have another Zoom that I have to do. But I think that the fact is that probably wedding is the most risky thing you can do. I got my COVID at a wedding. For example. All right. And I'm glad I went. It was a social obligation that I'm happy to provide, but that's where I caught my COVID. Fully vaccinated, and with all these lessons that I'm giving you about, I had irrational behavior, or at least I made a decision, that was a rational decision, and I came off on the losing side of it in that regard. In restaurants, I think eating outdoors is much safer. Outdoors is really relatively safe, unless you're in really a crazy situation where you're right next to people like this. Outdoors is because of the wind. Outdoors is actually a safer situation. So eating outdoors whenever possible. I like to see all these restaurants now that have outdoor dining even in the winter because they have heaters. And I think as long as they're well ventilated, some of them are not, but as long as they're well ventilated, I think that I think is a big plus. If you have to eat indoors, I would say, wear a mask going to the table, wear a mask when you leave the table, try to minimize your exposure in that particular way. Certainly wear a mask if you're going to the restroom. Basically you use common sense. It's spread by breath. Minimize your exposure to other people's air. And that's the most rational thing you can do at the present time. And by all means, get vaccinated and get boosted.
Thank you.
Rachel, we sort of promised Larry that we're
Yes.
gonna have a pretty hard stop right around now.
Yeah.
So don't let the rabbi close, but Larry, you were nice enough to allude to possible future appearances, topics, subjects, and so forth, and you've really been our guide through all of this. So we hope we can call on you again. There'll be big turns in the path in front of us and lots more things to discuss. Hopefully good things as well as challenging things. And personally, and for the congregation, I really thank you.
My pleasure, my honor.
Rich, anything you wanted to add?
I just want to thank Dr. Norton once again for your time. You're a very busy man, and you're an expert in the medical field. Just to conclude with one final question, similar to how Ezra concluded with practical advice. Assuming a person got both vaccines and then got boosted, what is the current opinion in terms to getting further boosted? You have to get it every year, every few months.
Well,
what exactly is the guidelines?
Well, one quick question, this practical question is, people come and say, I had COVID. Do I still need the bivalent booster, and when should I get it? The answer is yes, you do need it. And when to get it is a little tiny bit controversial. The CDC says 2 months after your COVID. Some experts say is 4 to 6 months after. I personally think that 12 weeks is probably the right the right period, balancing out between the antibodies you develop because of your COVID exposure and developing new antibodies moving forward. That's a practical question that comes up all the time. And I think in that regard, are we going to need boosters on a regular yearly basis like vaccines, like flu vaccines? Right now it looks yes, because we're constantly getting new variants. Okay, so it looks yes. I think the game changer is going to be the mucosal vaccines, the vaccines that are given intranasally, because they may be so effective at preventing the virus from attaching that we're not going to have asymptomatic spread. And if enough people vaccinate themselves that way, we can start to get enough of a level of herd immunity that we're not going to have to really worry about that sort of moving off in the future. The people who are developing the vaccines are developing basically intranasal ones that can be self-administered at home. So that, let's say, every 6 months or every 12 months, you would just take this gizmo and go sniff, sniff, and you'd be protected. And so I think that could really be the next big game changer that we're going to be looking for. And then that would really change the whole pattern. Also, people are working right now very hard on the RSV vaccine. We don't have one yet for the kids, and that working on that in regard. Also, because COVID is a coronavirus. Coronaviruses cause a lot of common colds. We actually may have a cure for the common cold coming up in that regard. So there's a lot of very positive things that are happening off into the future. And basically, I'm just going to have to come back at a later date and update you. That's it.
You're on. Dr. Norton, thank you very, very much.
Thank you all very much for listening. My pleasure.
Thank you.
Good night.
And Gail, thank you again.
Thank you.